Hello.
Yes. Yes.
Am I
Yes.
audible?
Yes. Yes. Audible.
Yes, ma'am, you are audible.
Hello.
Dr. Shukumar Sarkar, sir, I request you not to share the screen. Let
I got through the old link.
Hello.
Yes. Yes.
Okay.
Okay, okay.
Good evening, sir.
Exactly. Yes.
1 minute. This webinar on lead and conjunctiva. I request our all dignitaries to take the chair, sir. Hello.
Yes.
Okay, go on.
So now, hello.
Yes. Yes. Go on.
Continue, please.
Ah. Hello.
Joyashree, कौन है ला?
Hello. I welcome to the all dignitaries to chair the session. And today we will have a very good discussion on lead and conjunctiva. Hello.
yes, ma'am, please continue.
Yes. Yes. Continue. Continue. Continue.
So
What happened?
Hello.
Hello.
Jayashree, you are audible. Continue.
Hello.
It is
You are
okay.
audible. You are audible, Judge.
Hello. I am not audible. I am not listening anything. Hello.
Then
Hello.
Um,
Hello.
Unmute yourself. Unmute yourself.
It's unmuted, I think. Hello.
You are audible, ma'am. Jayashree, ma'am, you are audible. Please continue.
She
very
is
well.
not able to hear our voice.
Oh. Okay.
What happened? Jaharika is not visible.
Good evening, everybody.
Good evening. Good evening.
Namaskar.
Good evening, sir. Good evening, sir. Good evening.
Namaskar. This is the third webinar in the series at 4 o'clock. Sari bastile to sandhyale.
And here our esteemed teachers, Professor Sukumar Sarkar, Professor K.S.N. Rao, have been invited as honorable guests. And our students, they have come to teach us once again so that we can just freshen our knowledge on leads and conjunctiva. So knowledge has no end. So knowledge is a sinking star beyond the utmost range of human thought. So suppose you see a star in the horizon, it appears sinking. But as you go towards the star, again the star will appear sinking. So it has no end. So my dear friends, welcome to this webinar, and let us work together, think together. Sangat Saddang Sang Badadang Sang Mano Sangmo Manan Shijaratam Deva Bhave Jatha Purte. So please let us, the President of OSOS, I welcome everybody and request everybody to work together ahead. Thank you. Now I hand over the mic to Dr. Jayashree, if she is audible.
I think.
Okay. Then I request our honorable guest, Professor Sukumar Sarkar, to bless this occasion. Dr. Sukumar Sarkar.
Welcome, friends. I feel that as if I am Bhimsar Burla amongst you all. I feel blessed myself too to be amongst you in a webinar from Pondicherry. And definitely this is your novel attempt, starting with my favorite subjects, leads and conjunctiva, which I used to teach myself all along my teaching career. Leads, conjunctiva and refraction. Sarmishta might be knowing how strict I was in refraction.
Yes.
Definitely, I welcome you all. I bless the occasion. Let us proceed without delay. Thank you all.
Professor Kesan Rao. Professor Kesan Rao has joined.
Nahi, Rao to dishuni. Rao is not visible.
Then Dr. Shrikant. Are you here? Dr. Shrikant?
Yes, sir, I'm here.
Continue then. Continue the program.
So let's start with let's not waste time because the time is precious, and let's start gaining knowledge. I welcome Dr. Sharmishta to give a talk on leads. Dr. Sharmishta, all yours. Madam Sharmishta, madam.
କରୁଛି share କରୁଛି slide.
Sure. You can start your screen.
Pranam, the seniors. Actually, I feel sandwiched between the iconic generation of teachers and the ultra smart younger ones. So let us start right away. So I'll be talking about the eyelids. So we'll have to pay emphasis on the surgical anatomy of the lids. Each lid is divided into anterior and posterior lamella by the orbital septum. Now the anterior lamella has got skin and orbicularis oculi, which has got orbital part, palpebral part and lacrimal. The lacrimal part has got the Horner's muscle. Nerve supply is 7th cranial nerve. Orbital septum extends from the periosteum from orbital rim to the tarsus. This separates the pre-aponeurotic fat pad from the LPS and lower lid, whereas posterior lamella constitutes the tarsal plate and the tarsal conjunctiva. Then this is the diagram showing the anterior lamella separated from the posterior lamella. Understanding anatomy of the lid is complex and is of foremost importance in precisely assessing the patient before surgery. The orbital septum is continuous with the periosteum of the orbit and fuses with the LPS 10 to 12 millimeter above the superior tarsal border. Posterior to the orbital septum and anterior to the LPS are the pre-aponeurotic fat. This layer of orbital fat can be divided into the medial and the central fat pad. The medial fat pad is yellowish and the nasal fat pad is whitish. And this is of utmost importance to distinguish during surgery the central yellow orbital fat from the other part. Then what is of importance is the thin eyelid skin. It is less than 1 mm and it's important because it's of high mobility, stretches with age, excess available for full thickness skin graft. It has got no subcutaneous fat, no vertical excess of the lower eyelid skin. Hence, as much vertical dissection of the lower lid as possible should be done to avoid ectropion, lest when we stitch over, ultimately ectropion may be found. So what are the points to ponder is upper lid's incisions are preferably done in the skin crease, and when a flap or graft of thick skin is sutured to the thin eyelid skin, a small bite should be taken from the thin skin and a large bite from the thick skin to hold it right. So these are the various structures piercing the orbital septum, the lacrimal vessels and nerves, supraorbital vessels and nerves, supratrochlear, infratrochlear nerve, anastomosing vein between angular and ophthalmic vein, superior and inferior palpebral artery, aponeurosis of LPS, and expansion of the inferior rectus muscle. Then these are the upper lid elevators, LPS, molars, and frontalis. And when the LPS is not acting, the frontalis and molars become important. And this is a diagram showing, I'll be showing you a line diagram. This is important when we are considering Botox. These lines are of importance because they show a person's mood and the feelings. So they may appear horizontally, vertically. Show the picture. So here, the importance of eyebrows is and the glabellar lines is too much. In today's date, everybody is cosmetically conscious. So by brow lift, we can correct a lot of aging, like a person of 70 may appear as 50. This is the upper eyelid showing the various layers, the LPS, molars, orbital septum, and the conjunctiva. The LPS origin is from bone just above the tendinous ring, and it is inserted into the eyelid skin, tarsal plate, and conjunctival sac. Third nerve supplies it, and it has got sympathetic to the tarsal plate.
Pill is ejected.
So molars muscle, here we can see from the superior edge of the tarsus, molars muscle is around 12 to 14 mm. It is a smooth muscle, sympathetically innervated, and 2 mm elevation is required. Secretions of the eyelids are from the meibomian glands, glands of Zeiss and Mole, glands of Cross and Wolfring, which are the accessory lacrimal glands, also contribute towards the lids. So lower lid retractors, there is no true counterpart to the LPS, and therefore the opening movement depends upon several factors like traction exerted by the attachment of inferior rectus to the inferior tarsus and inferior palpebral muscle, which is identical to the molars muscle in the upper lid. Then this is the blood supply. The main arterial blood supply is from the lateral palpebral artery, which is a branch of lacrimal, and the medial palpebral, which is a branch of ophthalmic. Venous drainage, superficial and deep system. Superficial is located around 8 mm medial to the inner canthus and lies lateral to its artery deep in the skin. Lymphatic drainage, this is a very commonly asked question. So here most of the upper lid, lateral third of the lower eyelid and lateral canthus, they empty into the deep cervical nodes near the internal jugular vein, and the medial portion of the upper eyelid, the medial canthus and the medial 2/3 of the lower eyelid, they eventually empty into the submandibular nodes. So we come to the classification of eyelid diseases. These are, I have collected a variety of congenital deformities, though we could not cover them all. Epicanthic folds showing an extra layer of skin in the lower lid. Telecanthus, where there is increased gap in between two eyes. Coloboma. Microblepharon is a very small aperture in between the lids. And these are all the blepharophimosis, epicanthus inversus, epiblepharon, congenital upper lid eversion, ankyloblepharon, euryblepharon, which shows ectropion of the lower lid, then cryptophthalmus and congenital entropion. So classification of eyelid diseases continues with the acquired deformities. which constitute eyelid infections. This is a picture showing a diabetic ulcer in the lower eyelid of this person who is a diabetic. And this subsided with antibiotics and control of blood sugar level. This was an eschar form that was formed. Here I would like to say that Cuticel, that is a bactigras or paraffin embedded antibiotic, these help in very good dressing in such cases. And this is multiple chalasia with with internal hodulum formation. This is a herpes zoster, and this is molluscum. Here, the parents worry a lot, and this person was admitted. We had to perform the surgery under general anesthesia. All we had to do is just squeeze out the contents and put the patient on antibiotics locally as well as systemic. Here, this is a picture showing maggots. I'll be showing a video, and here this is a picture showing louse which I have collected from a textbook. And this is a lower lid rhinospore, which is very common in our part of Orissa. Now here I have got a video of Loa Loa. We identified morphologically, this person is a 35-year-old man who complained of a very thin thread-like structure which moved over his lids. And on surgery, we had to search a lot to find out this worm. It was removed in toto. And it kept moving in the container for some time. It was live for some time. Then this is a video showing maggots. You can see the maggots moving here. So what we did is, other than the turpentine oil, we crushed ivermectin and put it over the wound, and we also gave ivermectin, which worked a lot. Now this is showing a symblepharon, and these are eyelid malpositions, entropion. This is a case of congenital entropion. This is a corrected post-op case. This is involutional entropion and post-op. We did a Jones procedure for this. Then ptosis, SBSS was done. In all these cases, these are congenital ptosis cases, and I tried SBSS even with a 60-year-old man, and it worked well. And luckily, this person did not have amblyopia, though he had total ptosis. This is a case of bilateral ptosis. Here too, SBSS helps a lot. I'll show a video on that. And this is a case of ectropion. In this case, we did a lower lid shortening, and lateral tarsal strip procedure was done. SPSS. So this is a single stab SPSS surgery showing ptosis. You can also use a true cut needle. This is a very easy procedure and can be easily done. So it's a modified Fox pentagon technique. We followed Dr. Susan Jacobs' videos from YouTube and we did this. Our Android phones have helped us take these videos. Now we are comparing both the eyes. A little overcorrection is advised in such cases. So this is the final picture. And in entropion, we followed Jones procedure. So plication, what is done in Jones procedure is there's plication of the lower lid retractors, increasing their pull and creating barrier between the preseptal and the pretarsal portions of orbicularis. It can be primarily done and also it is done in recurrent cases. The vertical instability caused by disinsertion of lower eyelid retractors and overriding of pretarsal over the preseptal orbicularis is the cause. So here we have a video on entropion Jones procedure. Please bear with us. So we took the incision was made 4 millimeters beyond the lid margin and then dissected. This procedure gives very good results and hardly any scar. Then we can see the orbital fat. The stitch is being made through the orbicularis, through the tarsus. So 3 cardinal stitches are given, first at the central and then on both the sides and then 2 in between. This is the pre-op and the post-op picture of entropion by Jones procedure. When ectropion is caused by muscle and ligament relaxation due to aging, a small part of lower lid at the outer edge, and when the lid is stitched back together, the tendons and muscles of the lid will be tightened, causing the lid to rest properly on the eye. And this is a small video on ectropion correction. So we are giving this incision at the intermarginal strip, dissecting that part, and then shortening of the lower lid will be followed by stitching. These are very easy procedures. One has to just follow these cases. It's not a very clear video. the lateral part of the lower strip of the lower lid was taken and sutured towards the lateral canthus. That shortened the lower lid. I think I'll go over to the next slide. This is the pre-op photograph, and this is the post-op photograph of a case of ectropion. Then the allergic conditions and cystic lesions of the eyelid, and this is a picture taken from the text. Cysts, various cysts of glands of mole Z's, and this is the blackheads which are called comedones and milia. This is I wanted to show this video on dermoid to show the importance of cryotherapy in eyelid surgery. So cryotherapy acts by causing ischemia, and it causes destruction of small caliber blood vessels. Ice crystal formation occurs inside the cells, leading to cell wall rupture. And there occurs denaturation of lipid protein complexes. Vascular stasis also occurs, leading to loss of cellular and blood supply. The small xanthilesma and other small lid tumors can be easily excised with the help of liquid nitrogen or cryotherapy. So certain tumor-like lesions are like xanthilesma and foreign body granuloma. This is a picture of a 7-year-old boy who came up with this swelling, and the CT scan showed a small elongated structure. And on operation, we found out a thorn. This thorn had got this foreign body granuloma, which the child had for 2 years. Then this is a long list of treatment for xanthilesma, and it is seen these days that this YAG laser is working wonders for xanthilesma and other pigmentations around the eyes and on the face. Then benign eyelid tumors may be divided into benign epidermal tumors, squamous cell papilloma, seborrheic keratosis, actinic keratosis, and dermoid. Benign pigmented lesions like freckle, congenital melanocytic nevus, acquired melanocytic nevus. Benign adnexal tumors, syringoma, pilomatricoma, and lipoma. This is a case of lipoma which we had done. Here we had not used cryotherapy. Then capillary hemangioma, and this is a case of port wine stain. Then these are certain rare predisposing conditions like xeroderma pigmentosum, which is autosomal recessive. It's a genetic disorder. There occurs decreased ability to repair DNA damage by UV light. There occurs freckling in sun-exposed areas, resulting in dry and pigmented skin. These are certain syndromes which is maybe of importance to the postgraduates. Gorlin-Gos syndrome, which has myopia, strabismus, myelinated nerve fibers, and hypertelorism. Muir-Torre syndrome. This is a rare sebaceous adenoma of the eyelid. Bézek's syndrome, which is a paraneoplasia associated with squamous cell carcinoma of the head and neck. Immunosuppression prior to retinoblastoma and albinism. These are certain cases which we covered. So this is a case of basal cell carcinoma. Here we followed the Mustard's technique. Squamous cell carcinoma, this was not operated. We lost this patient to follow-up. Keratoacanthoma, here this is in the upper lid. Here we performed a TENSILs. I'll be showing the videos. This is a case of sebaceous gland carcinoma of the upper lid. Here also we performed a TENSILs. You can see the scar here. And this is a case of melanoma. This was also in the upper lid. We did a TENSILs here. And this is a Merkel cell carcinoma. Maybe this patient did not come up for surgery. And this is a case of Kaposis sarcoma in a HIV patient. So full thickness lid defect may either be small, where direct closure can be done. Moderate size defects, lateral semicircular rotation flap can be done, TENSILs. Tarsoconjunctival advancement flap, Hughes, and marginal pedicle rotation flap, that is Mustard's. Large size defects, breached advancement flaps like cutler beard and mustard's cheek rotation flap can be done. This is showing a schematic of mustards. So here, this shows cutting of the lower lid and then dissection of a semicircular flap. We release the underneath tissue, we pull it and we switch. I remember Dr. K.C. Mahanti, who was also my guide, he used to do these procedures very meticulously. So, and he used to take buccal mucosa and form the inner lamella of the lower lid. I'm sorry. Why that's not opening? I think I'll show the mustards later on. And this is a schematic of cutler beard flap. And this upper lid had a huge tumor. So this shows removal of the upper lid portion. And here we incise 4 mm below the lower lid margin, and then we dissect this part, and then we go beneath the lid margin and take the tissue and cover it. We can use ear cartilage graft or buccal mucosa to form the inner lamella. Here I'm showing a cutler beard technique. She had a huge mass of the upper lid. So we did it under local anesthesia, though general anesthesia is advised. This was done recently. We are doing a lateral canthotomy. The mass, which looked very small outside, was really huge. We clamped it with the artery, and then incision was given 4 mm beneath the lower lid margin. This is a full thickness incision to enable us to relax the lower lid from the underlying tissue and advance it forwards to form the upper lid. Then we would call the patient after 6 weeks and reconstruct the upper as well as the lower lid. The tumor was also cut with a 4 mm clear border, and the tissue was sent for histopathological examination. We do not have supply of radio frequency cautery, RF cautery, so we do it this way. Lest we would have a bloodless field and things would have been much more clear. So finally, suturing is being done, and the patient would be called 6 weeks later to form the upper as well as the lower lid. This is a pre-op picture, and here this is the final after we have done a Cutler beard procedure. Then ultimately after 6 weeks when the patient comes, we would incise here, we would pull it up, we would incise at this portion and form the upper lid, which would not have eyelashes, and the lower lid would have the eyelashes. This part of the skin would be sutured over here. Now, these are certain miscellaneous acquired disorders. This is a varicocele. This patient, when she used to cough, this portion used to come away. Here, we used a sclerosing agent, 0.2 ml of sodium tetradecyl sulfate, 1% was used. It was injected into this mass, and we waited for a day, and the mass reduced. We tied it up at we ligated it at both the ends, and then finally did the surgery, and this is the post-op picture, and she never came back with the recurrence. This is a case of blepharochalasis in almost a 50-year-old lady. She had sagging of the skin on the side, and this is the post-op picture. This is a case of bilateral ptosis with dermatochalasis, and this is a floppy eyelid syndrome. So what is the physiology of the blinking reflex? Blinking is of 3 types: voluntary, reflex, and spontaneous or involuntary blinking. So blepharospasm is a very cumbersome disorder where the person is feels insulted, especially in public. So here, this is a case of facial palsy with blepharospasm. So these are, I have given the spots, I have given the markings. The video is fast forwarded, and we gave Botox, and the patients are doing good. We buy 50 international units of Botox vial, and we reconstitute it with 2 cc of distilled water. And of this, when we take 0.1 ml, that forms 2.5 units. And we usually give 3 to 5 injections of Botox. Here also we can use Botox, but here tarsorrhaphy was done. And after tarsorrhaphy, this is the post-op picture. And this is another post-op picture. I missed out this pre-op photograph of this patient. This is a case of myasthenia. So myasthenia, we have started giving treatment for myasthenia. There's a huge list to its management, but we use tablet pyridostigmine 60 milligram BD for 2 months. Considering whether the patient is diabetic or not, you can add on steroids, and the patients respond very well. So thank you so much, all of you. And it is hard to cover up everything, but we tried our best. Team Vimsar has tried our best to put forth the diseases of eyelid in the OSOS webinar. Thank you so much.
Thank you, Dr. Samishta. Dr. Samishta was my teacher, and she nicely briefed up the whole subject, which is a very, very long topic. Each portion of the topic, like ptosis, ectropion, etc., can be a topic itself for discussion for a day. The efforts are well appreciated, ma'am. I'm pretty sure the PGs are lucky enough to have you as a teacher at Vimsar, and I envy these days now. So, is there any other questions? Because they have got no questions on chat. If any panelist has any question for Dr. Sharmishta. Ma'am, okay, I'll tell you. Let me start the discussion. When we were posted at Vimsar, there are a lot of ear injuries with to the leads. How often is it now? Is it there or not?
It's very rare. I have not found one since maybe more than a decade.
So because when we did it, we did it like 15, 20 years back, there were many. Madam, how common do you treat myomitis, which is underdiagnosed condition in at least our part of the country.
It's very common nowadays, and we do treat cases of myomitis.
Right. Okay. Any other questions? Subul sir.
Yeah, okay. It's a really nice presentation by Samnishta. Definitely, she has covered almost all the topics of leads.
The
What should I
mustard's
ask?
video was also there. I don't know. It did not open up. It was a nice mustard.
No, yeah, yes. And nice video of Loa Loa. How did you suspect that there is a worm inside? And how could you take out live worm?
The patient was very intelligent, sir. The patient said, this was during the COVID period. The patient said a thread-like structure is moving about from the lower lid to the upper lid, and it is severely painful. And so after I did local xylocaine, I lost vision of the worm. I could not find that thread-like structure. So I had to really struggle. And I was about to close, and I gave a small incision, and a wire-like thing pouted out. And from there on pulling it, it came out in totos.
Is it a single one, or do you get any multiple?
We found a single one, sir. We found a single one. But once Dr. Bhuya was operating, and it was a 10-year-old, it was a 10th class appearing boy. And he said something is moving about in my eye. And sir had operated, and we had found a male and a female loa in copulation. We took it to the microbiology department, and we saw the male, a small male and a very huge female. And we had also reported it. And this was a second case in my tenure.
Very good. Excellent.
Sir, Mr. This Loa case, was it isolated for seen in your department or pathology department? Could you get any feedback from them? Because one person only getting a parasite infection, it must be unusual. Other departments, pathology and skin, are they getting such cases? Have you got any feedback?
We have not got any feedback, ma'am, but we tried to get a proper identification from the entomology department in Kolkata, but we could not because of the COVID period, ma'am.
Oh,
we did not get any reply.
Now, earlier to this, have you come across any Loa in that area? I mean, in Sambalpur side?
Yes, ma'am. In Bhuya sir's time, we had reported one case.
Good one.
Right.
So, in our state, it's unusual to get Loa.
Right. So let's move forward. Thank you, Dr. Samnishta, for your fine nice film. Let's move forward to Dr. Priyal Mishra, Associate Professor of Premier Institute of the State of Orissa, AIMS, to take a tour of Conjunctiva. Dr. Priyal, are you ready? Can you please share your screen? Thank you, Dr. Samnishta. Dr. Priyal. Yeah.
Okay, I was thinking. नहीं मूवमेंट के लिए ट्रैफिक की तरफ से कौन उठे वो कंसल्टेंसी पर रेफरेंस पर
Dr. Priyal, you can please start.
Yes,
You aren't audible.
She's muted, I think.
You aren't audible.
Now I am audible, sir. Okay.
Yeah.
So it's really an honor to speak in front of my esteemed teacher. After Madam's topic, which was mostly surgical, my topic, diseases of conjunctiva, was most of the managements are medical, and so it may feel little bit of theoretical. I have it's a vast topic, and like as Madam told, it's very difficult to cover within half an hour. I will try to touch briefly each of the entity, and we have eminent personalities in our panelists. So I hope there will be a good discussion after that. So let's start it. So first, briefly, the anatomy, the palpebral part, bulbar part, and the fornicial part of conjunctiva. As we can see, this is the palpebral part. First is marginal part, and then along the tarsal, it is called tarsal part, and little small part, that is orbital part. And after the fornix, the bulbar part starts. The bulbar part is loosely attached to the tenon capsule and both insert to the limbus, whereas the palpebral part is quite adherent. And there is a sulcus subtarsalis. It is a groove situated 2 millimeter away from the lead margin, and it's a common site of foreign body lodgement. So in any complaint of foreign body, we should revert the lead and mostly search this area. And other things of importance are plica semilunaris and caruncle and palisades of Burke. So arterial supply of conjunctiva derives from peripheral tarsal arcade and marginal tarsal arcade and anterior ciliary artery. This is the dimension of conjunctival sac from limbus and from the lead margin. In some of the syndrome, like giant fornix syndrome, this superior fornicial depth may be more, so that it can give rise to chronic conjunctivitis. In this picture, we can see there are glands, lots of glands. The accessory lacrimal glands, glands of Krausen, glands, and the goblet cells, which are embedded in the conjunctival epithelium, mostly in the basal layer, around 10%. It constitutes around 10% of normal conjunctival epithelium. And meibomian gland, it is obviously inside the tarsus, and it's the part of lid. Histology, I will not go detail, but the epithelium and substantia propria. Epithelium is non-keratinized and around 5 cell layers thickness. And the stroma, which is a richly vascularized connective tissue layer, and it has two parts. The outer one is lymphoid layer, and below that is fibrous layer. The lymphoid layer in newborn is absent up to 3 to 4 months and first appear in the fornix area. And the conjunctival associated lymphoid tissue is present in this layer, which has a great role in immunological diseases. And second, below that there is a fibrous layer which contains the glands of Krausen and Wolfring, the accessory lacrimal glands. So coming to the diseases, we have categorized the disease: conjunctivitis, degenerative changes, cyst and tumor, and dry eye and ocular surface disorder. First, I will go to this cyst and tumor, then we will discuss rest other things. So symptoms, all of us know: redness, stickiness, normal foreign body sensation, lacrimation, photophobia. If mucus is a lot, there may be slight blurring of vision. And what are the signs? Hyperemia, discharge, follicle, papilla. If less than 1 millimeter, it is called macro. More than 1 millimeter, it is giant papilla. There can be granuloma formation. There can be hemorrhage, which can be large, subconjunctival or tracheal hemorrhage over conjunctiva. There can be chemosis. There may be membrane formation, which are true membrane. Those are adherent tightly, removal of which usually damage the layer, but pseudo is just an organized exudate. We can easily remove them. And last sequel is cicatrization. So coming to conjunctival cyst and tumor. First, cyst is primary epithelial inclusion cyst. As we can see, these are the conjunctival cyst. These are retention cyst, thin walled, and usually they contain clear fluid and sometimes turbid fluid. Usually they create no problem, but may need surgical treatment due to cosmetic reason. The cyst wall is excised under topical anesthesia, and bleeding should be encouraged so that adhesion can be formed, or cyst wall to be removed to prevent recurrence. There is another is secondary inclusion cyst, which usually appear after any surgery for strabismus or after any injury. This is secondary inclusion cyst. Next is a lymphangiectasia. This can look like this is cystic or sausage-shaped clear-walled channels. They may become filled with fluid, blood also. In those cases, these are called hemorrhagic lymphangiectasia. And there can be large, when that is called lymphangiomata, that is of large size. Or in normal cases, there is like beaded sausage-shaped appearance in the conjunctiva. Similar extension cyst of Krause can be seen, and subconjunctival parasitic cyst like cysticercosis or hydatid cyst are also found. Most of the pictures are, these are not mine, these are borrowed from standard textbook or downloaded. So coming to benign epibulbar tumor. First is dermoid. Actually, these are not true neoplasm, they are choristoma. Normal tissue in abnormal positions. Like these contains our skin, appendages, hair follicle, sebaceous gland, sweat gland can be seen, and sometimes also fibrous tissue. So when we try to remove them, they leave the cornea part is usually remain opaque. Previously, these areas were tattooed. Tattooing was done to disguise, but nowadays lamellar graft is preferred, and some also try mitomycin C grafting. These are dermolipoma. Dermolipoma, they usually fibrofatty tumor seen in outer canthus, and associated maybe some congenital syndrome like golden hair syndrome. And these are actually covered with stratified squamous epithelium. And the stroma containing various amount of collagen tissues, mostly which is adipose tissue. So it is seen in early in life and female. So what is the differential diagnosis of this? Is subconjunctival fat prolapse. So how to differentiate that? It is usually seen in elderly people and can be repositioned into orbit. And if we do some imaging, we can see that it is invariably continuous with the intraconal fat. This is subconjunctival fat prolapse, which is to be differentiated from dermolipoma, which is seen in early in life. So surgical resection when done, care to be taken that limited debulking, not to try to over exercise, just limited debulking that is acceptable for cosmetic purposes done. Now coming to conjunctival nevus, these are group of pigmented tumor, benign, then pre-invasive, and later we will talk malignant tumor. So congenital nevus, the most common group of tumor that is seen in ocular surface, that is conjunctiva. The nevus is most of the overall risk of malignant transformation is less. In this case, it can be of three types: junctional, subepithelial, or stromal. Junctional is within epithelium and stroma, and compound means it has two components, either epithelium or it may have a stromal component. So what are the signs of potential malignancy in nevus? When we suspect that this lesion can be dangerous, usually when they are present in an unusual site, like palpebral conjunctiva or fornix, when they are associated with prominent feeder vessels, or there may be a sudden growth or increase in pigmentation. Usually during puberty time, there can be some growth due to hormonal changes, but otherwise if the growth is more disproportionate or increase in pigmentation or develop after the second decade, then these are the signs of potential malignancy. Next come to congenital ocular and oculodermal melanocytosis, nevus of Otta. This is also congenital disorder. We can see the episcleral staining, episcleral melanocyte proliferation in this case, and in 50% cases there is associated ipsilateral dermal melanocytosis also. And melanocytoma is also a rare congenital lesion. It is slowly enlarging and that cannot be moved freely over the globe. Next, conjunctival papilloma. This can be pedunculated or this can be sessile formed. And usually they are covered with a multi-layered non-keratinized squamous epithelial cells. Sometimes these can also contain the areas of dysplasia. Usually this is on cytological finding that can have cytological atypia, epithelial thickening or leukoplakia, and goblet cell, lack of goblet cell. But clinically, what we should look for, if they show the signs of inflammation during our examination, if more inflammation is associated, if they have keratinization, or there is symblepharon formation, or palpebral conjunctiva involvement is there, then also these are the alarming signs. And a rare variant is endophytic. So these two are all exophytic. This is pedunculated and this is senile. So we should look for these signs, whether they have keratinization, they have symblepharon, they have more inflammation, then that is a chance of developing to malignancies more. So as I have told, some studies have shown that nevus is the most common. Next, our ocular surface squamous neoplasia, then primary acquired melanosis, which is a pre-invasive lesion, and then melanoma 12%, and next is our lymphoid tumor. In children, any of the tumor, they show malignancy only in 3% of time, because malignant tumor mostly seen in adult, where the most common is melanoma. Then squamous cell, then lymphoma, and Kaposi's and metastasis are less than 1%. So coming to tumors or ocular surface epithelium, benign papilloma, pseudoepitheliomatous hyperplasia, or benign hereditary intraepithelial dyskeratosis. Then pre-invasive is our conjunctival corneal intraepithelial neoplasia, CIN, and malignant is squamous cell carcinoma. It can have some variant like mucoepidermoid or spindle cell, which are more aggressive type of squamous cell carcinoma. So it is a squamous cell carcinoma that is pre-invasive. Together it is called ocular surface squamous neoplasia, under which conjunctiva corneal intraepithelial neoplasia is pre-invasive and frank squamous cell carcinoma is your malignant tumor. So among the risk factor, ultraviolet light, aging, human papilloma virus, smoking, fair complexion, or under immunosuppression. So if any young adult, if we are suspecting that it is ocular surface squamous neoplasia, then HIV serology test should be mandatory, because immunosuppression progress these conditions. It can have papilliform, gelatinous, and leukoplakia. This is the signs of leukoplakia. These are gelatinous appearance, and this is a papilliform appearance. And they can invade the cornea involvement like a translucent or sometimes a sheet-like, gray epithelial sheet-like. They approach from conjunctiva towards the cornea side, and with the characteristic fimbriated margin like pseudopodia extension. And rose bengal and lysamine green staining can be done to help these lesions. Now coming to squamous cell carcinoma, it is the invasive one. So involvement, when the involvement extend beyond basement membrane into stroma, then now it is the invasive form. So now it has the metastatic potential also. It is mostly seen in dark skin patient, and the overlying vessels will be engorged and highly congested. As we can see here, all these lesions are showing the engorged and congested conjunctival blood vessels. Mucoepidermoid and spindle cell carcinoma, these are the variants. And treatment should be resected as freely with the margin, and they should be microscopically confirmed that margins are tumor free of the tumor cells. And now with the advance of topical chemotherapy and modern surgical, the recurrence rate has been decreased. Previously it was around 50%, and now it is around 15%. And whenever required, cryotherapy, radiotherapy can be applied. So this is another is a complexion associated melanocytic proliferation. So these are this is benign one, TAM and PAM. These are pre-invasive and conjunctival melanoma. Then primary acquired melanosis. It is acquired non-cytic flat patchy diffuse pigmentation of the conjunctiva, usually unilateral asymmetric, and there is a secondary acquired melanosis also, which is usually seen in Addison's disease or if previous radiation has been done or sometimes in pregnancy. So when to suspect if the lesion is larger size, more than 3 clock hour, or in an unusual site like caruncular, fornicial or palpebral, or it is progressive enlargement, the feeder vessels are clearly seen and thickening, then should be suspected. Melanoma, it arises from PAM 70% cases, from navy 5% cases, or de novo without any pre-existing lesion, de novo in 25% cases. Care should be taken to exclude any ciliary body melanoma, which sometimes can extend through the sclera and mimic a conjunctival melanoma. So 25% of cases are amelanotic. Amelanotic melanoma are 25%. Because heavy vascularizations, the tumor may bleed easily. Again, I am emphasizing the poor prognostic factors are unusual site, more invasion, thickness more than 1.5 millimeter, eyelid margin when affected, that is again a poor prognostic factor, and lymphatic invasion. Metastasize to lymph node, brain, lungs, liver, and bone. So management again is circumscribed. Lesions are treated with excision, and when they can't be excised or diffuse category, only the nodular part is excised, then topical therapy or adjunctive radiotherapy, cryotherapy to the bed can be applied, or proton beam radiotherapy can be applied if it is involving caruncle or fornix. Mitomycin C cryotherapy and orbital recurrence if there, we should be exenteration is reserved for very extensive and aggressive disease, and otherwise local resection and radiotherapy are usually done to the recurrent cases. Basal cell carcinoma, most commonly this is a eyelid tumor but can invade conjunctiva from lid, and this is the conjunctival lymphoma. Salmon appearance, salmon colored, that is slight pinkish, slow growing, painless color. So excision biopsy must be done to determine the diagnosis. Sometimes systemic lymphoma may be associated, so a thorough systemic evaluation is done, and radiotherapy is effective in treating the localized conjunctival lymphoma. Kaposi sarcoma associated with HIV infection. This is usually can have some lesion in skin of eyelid or face also, highly vascular tumor. It is a malignant tumor. So radiotherapy is the treatment. Treatment is palliative with radiotherapy. Sebaceous gland, again eyelid malignancy. Epithelial invasion of conjunctiva is done in around 50% of cases, and cornea involvement is around in 25% of cases seen in older individual. And one thing is, this tumor can masquerade as chalazion or chronic unilateral blepharoconjunctivitis. So whenever a chalazion is long-standing, recurrent chronic blepharoconjunctivitis in an elderly patient, then suspicious around the sebaceous gland carcinoma should be done. So after the cyst and tumor, we will coming to conjunctivitis. Based on onset acute, resolving within 4 weeks, subacute chronic more than 4 weeks. Exudate serous, scatteral, purulent, mucopurulent, membranous, pseudomembranous. Response follicular, papillary or granulomatous. So there is a long list of agents bacterial, viral, chlamydial, fungal, and parasitic. Among Glaphairus, Staphylococcus, Haemophilus, H. influenzae, gonococcus and meningitis, viral herpes simplex, adenovirus, and chlamydia, fungal and parasitic. Besides infectious, in non-infectious category, we have allergic, irritants, endogenous or autoimmune, then toxic or facetious. So bacterial conjunctivitis, most common isolates are usually Streptococcus pneumoniae, Staphylococcus, Haemophilus. Hyperemia, sometimes it is mild hyperemia to fiery red, that is pink eye. And definitely there will be mucopurulent or purulent discharge. Flakes of mucopus are seen. If it is a gonococcus infection, the pus will be accumulate within very few minutes after clearing. Color halos can be seen. And in pneumococcal conjunctivitis, pseudomembranous is also found. The gonococcal infection is, these are virulent organism, can they intact testament membrane, they can. So it is the hyperacute, it is called hyperacute conjunctivitis or acute blenoroia. Lots of purulent discharge, they accumulate within minutes of cleaning, they again reaccumulate. In adult, it is called severe purulent conjunctivitis, and in newborn babies, it causes ophthalmia neonatum, which causes a very serious disease in newborn. Giant fornix syndrome, already I mentioned, due to voluminous upper fornix, it usually gives rise to a chronic conjunctivitis. This is ophthalmia neonatum. The most common cause is chlamydia, but gonococcus give rise to a serious infection, usually early in. This can be seen. The gonococcus is within first 48 hours, usually seen, or if there is some chemical reaction, that is also seen within 48 hours. Other bacteria, usually they can manifest 48 to 70 hours. Herpes simplex little later, after 1 week, and chlamydia trachomatis. And we should differentiate from nasolacrimal duct blockage, acute dacryocystitis, and congenital glaucoma. Because in first week, in newborn, there is no tear secretion. So even any discharge or even slight watery secretion also viewed with suspicion of any infections. So treatment is common to all broad spectrum antibiotic drug, frequent cleaning, oral analgesic or oral antibiotics if required, and for comfort, dark goggles can be used. I am not going to very detail because there is a lot of topics to cover. Then coming to trachoma. Trachoma is the world's leading infectious cause of blindness and one of the 20 neglected tropical disease and affecting over 1 billion of world poorest people. So 2020 data, 137 million people still are in endemic, trachoma endemic area and are at risk of trachoma blindness. And it is responsible for blindness or visual impairment in around 1.9 million people. This is recent data, 2020 data. So the pathognomonic is trachomatous follicle. How we differentiate? Now first is upper tarsal conjunctiva. This distribution is very characteristic. Mostly they are confined to upper tarsal conjunctiva, forming a row along the upper margin. And second is very early onset of cicatrization. These two things are characteristic of trachomatous follicle, where we can differentiate it from other viral or other follicular conjunctivitis. And also other corneal involvement in the form of superficial keratitis or ulceration or trachomatous pannus. These can also be seen. From that, we should suspect that it is a trachoma case. The WHO classification, TF, follicle stage, high for more follicles, at least 0.5 millimeter diameter, the upper tarsal plate should be there. And TI is intense. It is the active severe disease. These two are coming under active disease. Pronounced inflammatory thickening and obscure more than half of the normal deep tarsal vessels. As we can see, this is the tarsal vessels are seen and these are obscuring the more than half at least. So this is an intense phase. 5 or more follicles starting is the follicular phase, then intense, then scarring. This is the old infective part. And starts complications should be started here. And trichiasis phase needs corrective surgery. Lastly, opacity phase. So whenever comes to opacities, these are sequelae of trachoma will coming to. So this is a normal. This is follicular phase, intense phase. Here already scarring has been formed. This is the tracheatic stage and this is the corneal opacity phase. So treatment, this is it is a community problem. So a global effort in the form of safe strategy adopted by WHO in 1993. In 1996, there was global elimination of trachoma by the year 2020 that was known under GATE 2020. And in 2012, the global trachoma mapping project. All these things, actually all these things together are very successful. So what was the incident? Actually, half of mine is covered. That was around 7.5 million in 2002. It has been dropped in 2009 to 2005 million because of this strategy. And what drugs were administered? Systemic, 1 single dose of azithromycin, 1 gram was the drug of choice. Or we can give in local form tetracycline 1% along with the systemic. We can give tetracycline 1% eye ointment or azithromycin 1% eye drop for minimum 2 weeks. If azithromycin is not tolerated, alternative erythromycin or doxycycline can be given. And whether complete sequelae already done, then it needs tarsal rotation surgery. The two are posterior lamellar tarsal rotation and is bilamellar tarsal rotation. So coming to viral conjunctivitis. Viral conjunctivitis, the hallmark is serous or clear discharge. It can be caused by adenovirus, epidemic in the form of epidemic keratoconjunctivitis. And we can have a sore throat, history of and a common cold, and preauricular lymphadenopathy can be seen. And sometimes like enterovirus, Coxsackie virus, they can cause hemorrhagic conjunctivitis. So cornea can be initially affected like punctate epithelial infiltrate that can cause photophobia also. Later, discrete subepithelial opacities can be found. So non-specific treatment with mild decongestant and lubricating drop is usually sufficient. So now to differentiate acute follicular conjunctivitis and subacute or chronic, epidemic keratoconjunctivitis, herpetic and chlamydia inclusion conjunctivitis, pharyngoconjunctival fever, these are all acute follicular conjunctivitis, whereas drugs, some drug induced like pilocarpine and molluscum contagiosum and pediculosis, these are all, they lead to chronic follicular changes. Trachoma already we have discussed. Herpetic conjunctivitis, the diagnostic clue is associated vesicles may be found in lid or other part of face along with that, and condition is acute and conjunctival follicles can be seen. Cornea sensation is usually reduced. So these can, if cornea is involved, then dendritic corneal ulcer, from that we will know that it is herpetic conjunctivitis. So this is the reaction changes, artificial tears and initial follow-up is done. If there is involvement of cornea, then we will add antiviral. And fungal conjunctivitis can be Aspergillus candida, and the special one is rhinosporidiosis can cause conjunctivitis. Then come to some granulomatous conditions are there, systemic like tuberculosis, leprosy, syphilis, cat scratch, tularemia. These can all cause granulomatous conjunctivitis. Ophthalmia nodosa is one of the conditions, that is irritation caused by the hair of caterpillar, and another is lymphogranuloma venereum. Now coming to allergic conjunctivitis. In allergic, seasonal allergic, perennial allergic, vernal keratoconjunctivitis, atopic, giant papillary, flictenular keratoconjunctivitis. So in vernal conjunctivitis, cobblestone appearance of, these are palpebral, upper lid is hypertrophied, and giant papilla, they like cobblestone, flat top nodules. These are usually hard, consistently hard. and they will give a milky hue because the epithelium over them is thickened. So histologically they are hypertrophic papilla. And limbus, this is ornithranthus spot. They are also gelatinous nodule consisting of eosinophil and epithelial debris. In mixed, both can be found. Cornea can be first complicated, first in a diffuse superficial contact, and later on can give rise to sealed ulcer. And this is pseudo gerontotoxin. This is the opacity. So long list of therapy: antihistaminic, mast cell stabilizer, decongestant, because this is although this is less severe than atopic conjunctivitis and usually self-limiting, the child outgrows the disease, but still that time these things are to be, and it is aggravated in spring season. So these things can be done, and sometimes topical cyclosporin also needed. If there is a sealed ulcer or the papilla very large, then subtarsal injection or sometimes the surgical excision of giant papilla may be required. And a sealed ulcer debridement can be done or bandage contact lens can be given. And they can cause intern dry eye, so omega-3 fatty acids supportive nutritional support can be given. Giant papillary conjunctivitis usually due to soft hydrophilic contact lens or suture or prosthesis. So again, they can cause giant papilla, usually more than 1 millimeter size. So the cause to be treated first. Atopic, only I will tell the differentiating factor. It is more similar like vernal keratoconjunctivitis. But what is the difference? Because the symptoms are same but more severe and unremitting. Usually they have no tendency to heal. And it is usually associated with a systemic history of asthma or allergic rhinitis, eczematous dermatitis, and it develops in adulthood, whereas we find VKC in children. It is found mostly in adulthood. More severe symptoms, unremitting eyelid skin changes are seen, and associated with chronic sometimes blepharitis, staphylococcus, and murderiosis are common. There may be keratinization of lid margin, the Hartog sign, the absence of lateral portion of eyebrow, and Danny Morgan fold. These are lid fold, lid skin fold caused by persistent rubbing. Now, endogenous or immune mediated conjunctivitis are there. One is flictenular conjunctivitis. This is also one allergic condition caused by endogenous bacterial protein, mostly tuberculosis. Seen in bulbar conjunctiva, generally at or near limbus. So others are erythema multiforme, Retter, Behcet, and sarcoidosis also can cause conjunctiva. Then coming to ocular cicatricial pemphigoid, mucous membrane pemphigoid. These are a group of autoimmune diseases, blistering diseases. They cause type 2 hypersensitivity reaction, that is cytotoxic. We can see papillary conjunctivitis, first hyperemia and edema, then gradually fibrosis started, and this is the shortening of conjunctiva, severe pannus, and severe dryness of cornea. They can be seen keratinization of caruncle, and superficial in cornea, inferior, lead to inferior symblepharon can be, and sallowing of inferior fornix, severe dry entropy on tracheasis, and consequently opacification of the whole cornea. And toxic chemical also, some drugs, neomycin, gentamicin, these are iodopes. They cause type 4 delayed hypersensitivity. Bremonidine, anti-glaucoma drops, latanoprost, they also can cause conjunctivitis. Molluscum contagiosum, Theras valvi, these are can cause follicular conjunctivitis not due to direct infection, rather they are considered as toxic conjunctivitis. They release the toxic substance and can elicit conjunctivitis. Stevens-Johnson syndrome again is a systemic disease, and due to drug reaction usually can cause toxic epidermal necrolysis, that is a severe variant of Stevens-Johnson syndrome. So this is a cell-mediated delayed hypersensitivity. Sulfur methoxazole, sulfonamide group of drug, trimethoprim, acetaminophen, cold remedies, and anticonvulsant. So hemorrhagic crusting of the lead margin, papillary conjunctivitis, conjunctival membrane, and keratopathy can be seen. These are hemorrhagic lead crusting. This is papillary, and this is pseudomembrane formation, and this is keratinization of skin margin. These are late signs, keratinization and eyelid complications. So initial stage, adequate lubrication, if required punctal occlusion, topical trans-retinoic acid can be tried, and aberrant eyelashes should be removed, bandage contact lens should be given, and later on surgical procedure like mucous membrane grafting or superficial keratectomy, lamellar graft, which is usually preferred over penetrating keratoplasty, or amniotic membrane grafting can be done. Other non-specific like chronic exposure to smoke, dust, heat, alcohol abuse, late hour of sleeping, and concretions, misplaced hair, dacryocystitis, all these things can cause chronic. Another also miscellaneous group of limbic keratoconjunctivitis, ligneous conjunctivitis. So coming to degenerative changes, all of us we know this is concretion and hard yellow spots in the palpebral conjunctiva. If they give foreign body sensation, they can be removed with needle. And pinguicula can cause inflammatory, sometimes inflammatory reactions, pinguicula, and pterygium. Pterygium and pseudopterygium. Pseudopterygium is a non-progressive, usually due to some chemical injury, result of some chemical or other injury. So it's an inflammatory procedure. It is non-progressive, stationary, and can be seen in any quadrant. A probe can be passed under pterygium, but it is highly adherent to the scar tissue. So this is pseudopterygium. As we can see, this is a pseudopterygium, and this is our normal pterygium, which can have a progressive, regressive stage, and it is excision with autologous conjunctival transplant is the treatment of choice. Symblepharon can be the sequelae of so many conditions. Conjunctivochalasis, this is the redundant conjunctival fold, can be seen, and if they give discomfort, they can be resected. Otherwise, artificial tear, conjunctivoplasty can be done. Otherwise, artificial tear will do. So there are other some miscellaneous conditions like argyrosis, chronic exposure to silver poisoning. There is a caruncular and conjunctival, as we can see, there is pigmentation. There is also deposits in cornea also. This is argyrosis. And otherwise, besides that, other skin, mucous membrane, these can also found to be darkened. So now coming to dry eye syndrome and disorders of ocular surface, just briefly I will cover. First is xerophthalmia. Mostly the malnutrited patient in developing country, and in developed country usually the cause is unusual self-imposed dietary practice, chronic alcoholism, and malabsorption due to cystic fibrosis or biliary cirrhosis or bariatric surgery. And infant, usually those are malnourished infant born to vitamin A deficient mothers, which have another biological stressor like either a measles infection, herpes, or other viral bacterial infections, or a episode of diarrhea. Those are risk factor for developing xerophthalmia. Xerophthalmia signs we know: increased keratinization and squamous metaplasia. They look like, they give the characteristic bitter spot. This is the bitter spot foamy appearance. This is due to Corynebacterium xerosis producing the metabolize the debris and producing, giving the foamy appearance. Sometimes non-responsive bitter spot is there. That means the serum retinoic acid, it is corrected vitamin A level, but the bitter spot persists. It is called non-responsive bitter spot. And cornea, corneal xerosis too. Sometimes xerotic plaque can be seen, and in severe cases keratomalacia. And xerophthalmic fundus, that is the white dots we can see. This is xerophthalmic fundus. And who grading? This is night blindness. X1 is conjunctival xerosis with bitter spot X1b, without bitter spot X1a, with bitter spot. 2 is cornea xerosis, 3 corneal ulceration, and XS is corneal scar, XF is xerophthalmic fundus. So what is the treatment? Less than 6 months, usually oral preparation is best. Oral preparation is oil based. This is preferred unless the diarrhea or vomiting, severe diarrhea, profuse diarrhea or persistent vomiting or malabsorption is there, in which case we use the intramuscular dose. The intramuscular dose is the half of the oral dose, but the schedule will be same. We need 3 at the diagnosis, then after 24 hours, and then third dose is at 2 weeks. So accordingly, 50,000, 1 lakh and 2 lakh. This is the oral dose, retinal palmitate, that is given orally. Along with it, we should give protein calorie supplement, vitamin, multivitamin A. For local treatment, intense lubrication, retinoic acid to prevent secondary infection, sometimes antibiotic to be given. And prevention is always better. So what is the prevention according to WHO recommendation? If children are suspected to be having vitamin A deficiency, 1 year to 6 years, we will give 2 lakh international unit.
Dr.
And
Priyadashini,
okay,
we are
I will just,
getting there.
I am finishing, okay. So dry eye, just I am covering the slide. This is the surface training score and lysamine fluorescent. There are lots of new, this is the advanced tear scope, and tear film osmolarity can be now checked in clinic OPD basis. So thank you all of you for your listening with patience.
Thank you, ma'am. It was wonderful, like wonderful in the sense, like it's a very difficult thing. But then I have to stop at some point because it's getting dinner time for many of us. And Dr. Das, Professor Gurusar Das, you're there. Have any comments before Dr. Sabyasachi Patnaik concludes? And thank you, sir, for organizing such a wonderful topic.
Oh, so actually these two topics were very much educative for us. We had forgotten since a long time, and many of us could revise our knowledge. So I thank both the speakers. Next, Sabyasachi is here. Hello. Sabyasachi is there, Sabyasachi? Hello.
Hello?
Sabyasachi is there?
I don't think so he's there, sir, because I saw in the list of participants, he's not there. You can put any concluding remarks, sir.
Okay. So I thank our honorable guests, Professor Sukumar Sarkar, Professor K.S.N. Rao, both of them are our teachers, and K.S.N. Rao could not join, and all the panelists and discussion, Professor Anita Panda could not join, and especially the speakers, they are our students, but they acted and they worked also as a teacher now. So we could learn many things from their lectures, and these lectures are actually useful for the students and for the general ophthalmologist and for us who have no library facility. They can revise their knowledge. So I thank you all. We will see once again after 1 month or so. Thank you.
Thank you, sir.
Okay.
Thank you, sir, and thank you all of you.
Yeah, thank you so much from the side of your licenses for giving us opportunity to associate with you, sir. And in future also, we will be assisting you for this platform.
The request is the network should be very cooperative. The network is coming and going. A lot of disturbance in the network.
I hope this is at your level, because sir, unless until you join with the Wi-Fi, you will not be able to have a clear voice. You need another Wi-Fi.
Sometimes there no picture, sometimes no voice, like this only. Again it is connecting, then disconnecting, like that only.
Yes, sir. I will look into it, sir.
I especially thank the Synovia people.
Thank you, sir. Thank you.
I especially thank the Synovia
Thank
people,
you.
Chandan, Puneet, and others. So for their cooperation. Thank you.
Thank you, sir. With this, sir, I end this meeting.
Okay.
Can we close the meeting with
Right,
your
sir.
permission?
Okay, sir.
Right, sir. Thank you, sir. Thank you.